dissection are the four common things which has been associated with the Marfan syndrome, where you may see here the height with the arm span exceeds the height, and the young patient with the diastolic murmurs. So speaking, let's come back to the murmurs. So we know that the Marfan syndrome is associated with the four things: aortic regurgitation, mitral valve prolapse, thoracic aortic aneurysm, and aortic dissection. Now coming back to here, the murmur area, we have the diastolic murmur which has been given up there. While in the mitral valve prolapse, you may have the systolic crescendo murmur with a mid-systolic click. That click will be heard in the mitral valve prolapse, but we are having here the aortic regurgitation. So aortic regurgitation, you will see the high-pitched, you will see here the high-pitched blowing murmur. You will see the high-pitched blowing diastolic decrescento murmur. High-pitched blowing diastolic decrescento murmur. I hope you can, my handwriting is not confusing you. Can you able to see it clearly? Hope I'm not writing, I'm writing a little legibly. Hope for that.
Yeah.
Okay, so speaking about that, the diastolic murmur, which is a high-pitched blowing and on the decrescento in nature, is common associated with the aortic regurgitation. So based on the severity, the diastolic murmur will be compromised. We don't need to dig into that deeper, but we can say the options, given options, and compare it to the question which was given, we can able to conclude the answer is the aortic regurgitation. Okay, in order to remove this, the other options as well as, so we see the coaction of aorta. In the coaction of aorta, you will see the systolic murmur again. You will see the systolic murmur in the coaction of aorta. And in aortic stenosis, yes, again the systolic murmur, especially the systolic ejection murmur. And in the mitral stenosis, you may see a little bit of a diastolic murmur, but it is heard in the apex, not on the second right intercostal space, because the second right intercostal space belongs to the aortic area. So in the mitral stenosis, you may heard that in the apex, or the apex, not on the aortic area. So with the based on the options we have, we can conclude that as the aortic regurgitation is a good options that you may have. So next about the things we are going to talk about is the third one. The next one is the third one which we are going to talk about. So the third one is a 19-year-old students present with sudden onset of fever, headache, neck stiffness, and a purpuric rash. Fever, headache, neck stiffness, and a purpuric rash we are having. So speaking about that, fever, headache, neck stiffness, and purpuric rash, this is a classical sign of your meningitis. Classical symptom of meningitis. Symptom of meningitis. So we have a variety of organisms which causing the meningitis, but the purpuric rash will focus us predominantly over the meningococcal meningitis. Meningococcal meningitis. Okay, so the treatment of choice, the management of choice they have been asking. So we are having this management protocol for the meningococcal meningitis. So speaking about the meningococcal meningitis, so you have to immediately recognize the symptoms as well as the purpuric rash. So the possible complication this patient may enter is the potential DIC. So initiate IV ceftriaxone. Initiate IV ceftriaxone, which is the optimal treatment. IV ceftriaxone of 2 grams should be administered even before the LP if delay is expected. But if it is preferable to take an LP and give the ceftriaxone 2 grams. Okay. And what is the ideal management after the IV ceftriaxone? Is more watch for the septic shock. This patient may progress into the septic shock and organ dysfunction. So we have to watch for the septic shock. And not only that, we have to initiate the prophylaxis for the close contacts. The prophylaxis of close contacts would be varying from rifampin to ciprofloxacin. Okay, rifampin, ciprofloxacin.
I think we have some network issue. Hello, Dr. Saktivel. Mm, mm. Sorry for the inconvenience. We'll be back soon. I think there is some network issues from Dr. Saktivel's side. Please wait for a while. Thank you.
Okay, can you guys able to see it now? The screen and my voice.
Yeah, I can see.
Okay. Okay. So we were in the sixth question, if I'm right. Right? I hope if you
Yeah,
could hear my screen and if
I
you hear
think
my voice and see the screen properly, you can say yes, I can go for that. Or we have to go back from question 4. I will go back from the previous questions.
please go back from question number 4.
You want me to go back from the question number 4? Okay. So I hope the slide is now visible.
Yeah, it's visible. You can go.
Oh, okay. So speaking about this, the question we have here is a HIV positive patient. HIV positive patients presents to the emergency department with a history of fever and visual disturbances. CSF analysis shows gram positive capsulated organism and India ink stain positive. And India ink stain positive. The causative organism is. So here we have this, almost we have this 4 to 5 clues. The first clue on the question here is the HIV positive patient. So the patient's immune system is compromised. The patient is immunocompromised. He have a fever and visual disturbances. That could be the meningitis. So the doctor there had ordered the CSF, and the CSF showed gram-positive capsulated organism with India ink stain positive. Okay, we got the another clue. The CSF analysis showed gram-positive capsulated and India ink stain positive. So the options here we got is the tuberculosis, CMV, cryptococcus, toxoplasma. Okay, speaking about the tuberculosis meningitis, the tuberculosis meningitis is an acid fast bacilli. The tuberculosis meningitis is a acid fast bacilli, and it acid fast bacilli. Speaking about this, we can say it's a non-capsulated yeast. Okay, and it does not stain on the India ink also. And same like with goes with the CMV encephalitis, it's a viral encephalitis. So they may have given you the other one. Yeah, the other feature here, which is prominently given here, is a visual disturbance. The CMV encephalitis could cause retinitis as a visual disturbance, but here the CMV will not stain on the India ink. So the third option is a cryptococcus meningitis, which is a most common one. So the option drives us to the cryptococcus meningitis and toxoplasma gondii. We see the ring enhancing lesion on the CT. Okay, we see the ring enhancing lesion on the CT. So the correct option here is cryptococcus meningitis. The correct option here is the cryptococcus meningitis. And the treatment of choice for the cryptococcus meningitis patient with meningitis is amphotericin B plus amphotericin B plus flucytosine. Okay, flucytosine. Okay, amphotericin B plus flucytosine for induction, followed by fluconazole for a consolidation and maintenance therapy. So HIV positive, optic nerve involvement, gram-positive capsulated, India ink stain positive narrows us to the cryptococcus meningitis. So you may see the high CSF opening features. So the drug of choice we are here is amphotericin B plus flucytosine. Okay, when you are giving an amphotericin B, you should always monitor for one thing. What is that one thing you always monitor for when you are giving an amphotericin B? You always monitor for your kidney function because the amphotericin B can puncture your kidneys. Okay. So this is a answer for this question. So we have seen a 2 question related to the meningitis. Previously, we saw the meningococcal meningitis. The drug of choice for the patient is a ceftriaxone 2 gram. And here we saw the cryptococcus meningitis, the immunocompromised individual. So here we have done this too. Shall I proceed? I'm going to the question number 5. So the question number 5 here is 19-year-old male presents with the progressive swelling of limb and face with the lab investigation reveals as follows. So we got labs. Lab shows 4 plus proteinuria with a low serum albumin and total cholesterol of 310, and we have a nil RBCs. So 3 plus proteinuria indicates that the patient has got a nephrotic syndrome. Considering the age, 4 plus proteinuria, and renal biopsy. Here's the clue lies here, people. Effacement of podocyte food processes. All these things narrows us to the minimal change disease. All these things narrows us to the minimal change disease. So minimal change disease, the diagnostic criteria should be the effacement of food process in the electron microscope, serum albumin of less than 3, and proteinuria of more than 3.5 grams a day. Okay, and the patient age, most common nephrotic syndrome in children and young adults. But the selective proteinuria is always a minimal change disease. So the diagnosis here is minimal change disease. But is that the thing that was asked on the exam? No. What was the thing that was asked on the exam? In the exam, they asked for the treatment of choice. The treatment of choice when we are going towards the, minimal change disease, 90 percentage of your uh, minimal change disease is steroid responsive, so we can give oral steroids. So here the treatment of choice here is oral prednisolone, that too 1 mg per kg per day for 4 to 6 weeks, and then we will try titrate them, and then we will try titrate them. Okay, and speaking about that, what are the common things we have to ask for or watch on this patient is steroid side effect and relapse. Okay, we have to watch for the steroid side effects and relapse. So why not the other options that we have? ACE inhibitors. Yeah, ACE inhibitors will reduce the proteinuria. It can be used as a symptomatic, but not as a primary treatment. And rituximab, mostly we used to reserve those rituximab for the steroid resistant patients or frequently relapsing cases patients. So because we have it's a monoclonal antibody, so we have to hold it for the higher levels. So here the treatment of choice, and the right answer goes for the minimal change disease is oral prednisolone. So the correct answer is 1 mg per kg per day for 4 to 6 weeks, and then we taper it. Okay, so this is the one. Now next we move on to the sixth question. So the sixth question is the treatment of choice in SLE with only skin and joint involvement. Obviously, it's a hydrochloroquine. For a skin and joint, it's a hydrochloroquine and methotrexate. Whomsoever is unresponsive to HCQ, we go for the methotrexate. Methotrexate will be the demand of choice if the patient is not responsive to HCQ. Okay, because methotrexate have a toxicity profile high. Then we have a prednisolone. Speaking about the prednisolone, it is useful for the organ dysfunction or organ threatening like disease. So not on the simple stuffs, because we have this osteoporosis, we can get infections that was in the SLE. So with considering those factors, HCQ is always a first line of treatment. So the answer here is a hydroxychloroquine. Okay, so moving on to the seventh question, Bacillus stearothermophilus is the most common indicator of, yes, it's a heat resistant bacteria. So basically we have a various amount of sterilization methods. So hot air oven, autoclave, ethylene dioxide sterilization, and dry air. Most commonly, this Bacillus stearothermophilus is most common indicator for autoclave, is a most common indicator for autoclave, because for the normal thermophilic area 55-60 degree, it can be survived. So we need to have a proper autoclave cycles for the Bacillus stearothermophilus. Subtilis is an indicator for hot air oven, and atrophius is an indicator for ethylene dioxide sterilization, the other organism. So pretty straight questions. Next we move on to the high quality CPR. So speaking about the high quality CPR, as per the AHA guidelines, the high quality CPR possesses a few things. So the first option is a depth of 5 to 6 centimeter. Yes, it's correct. In inches, the AHA will provide you with the inches of 2 to 2.4. 2 to 2.4 inches or 5 to 6 centimeter. So the compression depth should be at least bare minimum of 5 to 6 centimeter. Okay, that ensures the adequate cardiac output without any injury. And number two, ratio 15:2 breath. Nope. 15:2 breath is for two things. What are that? It is for the child or infant CPR. For the adult, it is a 30:2. 30:2 for the single rescuer with the adults. If you are moving on to the 15:2, it is for the two rescuer with the infant or child CPR. And number three, frequent passes for the pulse check every 30 seconds. Is it right? No. Every 2 minutes, every four cycle of CPR, you will get one pulse check. So that means after a full four CPR cycles, okay, or after a full complete cycle, which involves the 4 times 30:2 ratios. And the compression rate is 60 to 80? No, the compression rate is 100 to 120. So there is a CPR and there is this high quality CPR. So the standards which has been set by the AHA during the ACLS support for the high quality CPR is depth of 2 to 2.4 inches with a compression ratio of 30:2 for the single rescuer and 15:2 for the two rescuer or infant or child CPR, and the frequent passes for every 2 minutes once, and the optimal compression rate for should be 100 to 120. And apart from that, you should allow the chest to complete recoil. You should not press fast and fast and fast and fast in a hurry. You should allow the complete recoiling of the chest. That is an additional character of the high quality CPR. And rotate the person or rotate the compressor in every 2 minutes to prevent the fatigue and minimize the pre-shock and post-shock passes to less than 10 seconds. So these are the qualities of the high quality CPR. What are they? What makes the CPR as a high quality CPR? Number one, as a depth of 5 to 6 centimeter or 2 to 2.4 inches. The ratio should be 30:2 for single rescuer, 50:2 for two rescuer or infant or child CPR. Three, the pulse check done on every 2 minutes once. The compression rate should be 100 to 120, and allowing of the complete recoiling of chest and rotation of the compressors every 2 minutes, and minimization of pre-shock and post-shock passes to less than 10 seconds. These are the additional these are the quality that makes a CPR into the high quality CPR. I hope you guys got it. I'm moving on to the next area. I'm moving on to the next question. Hope you guys understood. So moving on to the next question, which of the following doesn't require a shock? Okay, so here it's another ACLS BLS question. So we have the two types of rhythms on our ACLS protocol. One is a shockable rhythm, another one is a non-shockable rhythm. Okay, one is a shockable rhythm and another one is a non-shockable rhythm. So here, what are the options we have given here? And then we will talk about the shockable, non-shockable rhythms. So the first one is a ventricular tachycardia with the pulse, ventricular fibrillation, pulseless VT, and pulseless electrical activity. Pulseless electrical activity. So we got these two things. So the non-shockable rhythm. What are the non-shockable rhythm? The non-shockable rhythm are PEA and asystole. The non-shockable rhythm are PEA and asystole. But here we have the VT, and here we have the VF, and here we have the pulseless VT. Okay, here we have the pulseless VT. Since on this three option, I got a two here, right? Maybe the options have been misinterpreted. Okay, so here we have the two right answers. One is a pulseless electrical activity, another one is a VT with a pulse. So because VT with the pulse, we basically uses it for the, like we uses a rate control or rhythm control drugs rather than the shock, because we have the VT with the pulse is technically the patient is hemodynamically stable and requires antiarrhythmic, antiarrhythmic agents. So pulseless VT and the VF, we obviously go for the shock. Okay, so this is all about the shock and shockable and non-shockable rhythm. So next is the mother says her child is left-handed. So pediatric developmental milestones. Okay, in which age group does she knows that the child is left-handed? Okay, very good. The options here we got was 6 to 12, 12 to 24, 24 to 48, and 4 to 5 years. 12, 6 to 12, 12 to 24, 24 to 48, and 4 to 5 years. So dominance can be visible mostly by 4 to 5 years. Hand dominance can be visible by 4 to 5 years. Okay. Hand dominance before 18 months may indicate the contralateral hemiparesis or neurological abnormality. Okay. Early forced handedness should be avoided because it may affect the natural neurological development. Because some parents, they push the baby to, they give it to the other hand. They give it to the other hand because we have the custom sometimes, like they don't take it in the left hand or something else, right? So this forced handedness should be avoided naturally with the babies. So speaking about the other milestones, 6 to 12 months, what does the infants use? Both hands equally with a clear preference. Speaking about the hand-on skills, infants use both hands equally with a clear preference in 6 to 12, and at 12 to 24 begin to show the preference on the dominant hand but still inconsistent hand use, and 12 to 48 months transitional period with emerging but not established dominance. You cannot say, you may see that the patient is using or the infant is using a dominant hand, but you cannot say it was established dominance. By 4 to 5 years, it's a clear, consistent, and established dominance.
So
Okay.
can you go to question number 9?
Yes. We got a question number 9, cardiac arrest algorithm. Yes.
So it was not pulseless electrical activity. It was just a pulse electrical activity option.
Okay, so pulse electrical activity. So in this case, we go for the option of ventricular tachy with the pulse. Okay, hopefully it got corrected. So it's a pulse electrical activity. So since it is a pulse electrical activity, we remove this option as a right. So we got a non-shockable rhythm. So in the non-shockable rhythm, PEA, asystole, and here we both don't have. So we have the option of ventricular tachy with the pulse. Okay, because the patient is hemodynamically stable. The optimal drug of choice in this patient, it could be any antiarrhythmic medications like a flecainide, procainamide, because we use this, sodium channel blockers as a primary choice, or in case of emergency, we can use amiodarone. But amiodarone, we will avoid it as much as possible because of the narrow therapeutic index. I hope it's easy. So we're moving on to the Brody's abscess. Oh, we got a question number 11, right? The shelf life of platelets at 4 degrees Celsius. Shelf life of platelets at 4 degrees Celsius. Okay, we got a 5 days, 10 days, 15 days, and 20 days. So speaking about that shelf life of platelets at 4 degrees Celsius platelets indicates that it is a cold storage platelets. So CSP. So speaking about the CSP, nowadays research says, the American Red Cross Association says, the storage of the CSP at a 1 to 6 degrees centigrade can prolong the life from 2 weeks to 20 days. So here we got a two options, which is merging with them 15 days and 20 days. Since it is a maximum one, I rather go for the 20 days rather than the other ones. Okay, so this is the one. And next is a Brody's abscess. Speaking about the Brody's abscess classification, Brody's abscess is mainly seen in subacute osteomyelitis. Mainly seen in subacute osteomyelitis. So we can say acute osteomyelitis also, but osteomyelitis is a systemic toxicity. So you won't see the bone abscess most probably. Okay, so you will see the periosteal reaction on the X-ray with the less bony changes, but the Brody's abscess is a hallmark of subacute osteomyelitis. Since it is a very straight one, I will move on to the next question. Okay, An old man aspirates the betel nut. Okay. The foreign body is most likely to lodge in. So the old man aspirates the betel nut. It creates an airway emergency. It creates a airway emergency. So the right option here is a right main bronchus. The right option here is a right main bronchus, because trachea, only the larger objects will, larger object will pass on to the trachea, and we have the left main bronchus and right main bronchus, and then we have a larynx. Okay, if the patient is having a betel nut lodged on the larynx, it would cause an immediate severe obstruction and coughing. So object very rarely lodges. Okay, so larynx is a rare, trachea, the object has to be larger. So we got two options here. One is a left main bronchus and right main bronchus. So the left main bronchus are more angled compared to the right main bronchus. Left main bronchus are more angled compared to the right main bronchus. So the left main bronchus, the betel nut goes into the left main bronchus is very, very unlikely. So the most common, the most common position where the betel nut could be found here is the right main bronchus. Since it is a right main bronchus, you should use the bronchoscopy for the removal. You can check it out on the X-ray with right middle lobe or right lower lobe, which is the most common specific location. If not, what will happen? The most common complications, yeah, obviously, the patient will develop atelectasis, bronchiectasis, pneumonia, and potential life-threatening complications. But mostly we used to remove it through the bronchoscopy in the emergency. So that's it. So the option right answer here is the right main bronchus. The right answer here goes for the right main bronchus. Okay, let's moving on to the next question. Moving on to the next question. According to the Nepal MTP law, up to what gestational age is medical termination of pregnancy allowed in case of incest or rape? In case of incest or rape, up to 18 weeks is allowed. Okay, incest or rape up to 18 weeks is allowed, but here we don't see the options of 18 weeks. So, according to the Nepal MTP guidelines, the gestational limits for the general request is up to 12 weeks. General request is up to 12 weeks, and up to 18 weeks is incest or rape. Incest or rape goes for up to 18 weeks. Up to 18 weeks. Fetal anomaly will go for up to 28 weeks, and any gestational age if the mother's health is at the risk. Okay, hopefully the option might be somewhat incorrect. Hopefully we have corrections later. I hope it was okay. Okay, so the option here should be
Hello,
a
sir.
yes.
According to the Safe Motherhood program in Nepal, in 2018, an act was made which said it was 28 weeks for rape and incest.
Okay, so to the rape and incest, it was made it up to 28 weeks. Okay, but Nepal MTP law, maybe, yeah, fetal anomaly, it was 28 weeks. Yeah, maybe the corrections, I will correct it up. Sure, thank you. Thank you for the correction. Okay, next we go for the constant PP and RR interval. Next we go for the constant PP and RR interval in ECG. Constant PP and RR interval in ECG is complete electrical dissociation between the atria and the ventricle. So the common one, the answer here is the complete heart block. Okay. In a Brugada syndrome, you will see the ST elevation in V1 to V3. ST elevation in V1 to V3. Okay. And PR relationship will be maintained. In second degree heart block, in a Mobitz 1 or 2, occasional missing of P wave will be seen, or regular missing of P wave will be seen with the sudden drop to QRS complex. And VT with the AV dissociation, possible with the PP and RR interval, but there is a wide QRS complex. Okay, there is a wide QRS complex. Since it is not mentioned on the question, I rather go for the complete heart block. Okay. Next is a carpal tunnel syndrome. The nerve involved in the carpal tunnel syndrome, it's a pretty straight median nerve. Okay. The nerve involved in the carpal tunnel syndrome, it's a pretty straight question, median nerve. And the next one, we have the autopsy findings, the findings of gallbladder and the autopsy of the death from starvation. In a death from starvation, there is absence of food intake, there is no CCK. So when there is no CCK, there is no gallbladder contraction. So you will see it is a fully filled with the bile. It is fully filled with bile. That is the right answer here. Okay, because of the patient is on starvation, no food means no CCK, no CCK means no gallbladder contraction, no gallbladder contraction means accumulation of concentrated bile. So the gallbladder became distended, turgid, and fully filled with bile. Okay, and next we move on to the next question. Lowest MAC value. So speaking about the lowest MAC value for the following drugs: sevoflurane, nitrous oxide, and desflurane and isoflurane. Okay, isoflurane is having a lowest MAC of 1.2%. And desflurane is having a MAC of 6 to 7%, and N2O is having a highest MAC of more than 100, which is a 105%, and sevoflurane it is approximately 2%. So the competitor here with the lowest MAC value is sevoflurane and isoflurane. So the isoflurane will go as a winner, okay, because it is the lowest and most potent. Okay, if they ask you the least potent, what would be the answer? N2O will be the answer. N2O will be the answer. Next one is a PDPH. So PDPH prevention, neuroaxial anesthesia complications. So post puncture headache. Okay, so mainly which of the following is the measures? Use of the Quincke needle, pencil-shaped needle, anesthesia given in L3, L4 instead of L2, L3, uses of IV fluids. So mainly the Quincke rises the PDPH. Quincke rises the PDPH, not the lowers. And anesthesia at the wrong location, nope, it doesn't prevent it. And the use of IV fluid, it doesn't reduce the incidence but help to treat. It is used for the treatment but not for the prevention. So pencil shaped needle is a option which we go for the right here. Okay, some argue that uses of IV fluid will also help, sir. Yeah, it helps after the patient develops the headache and you have to suppress it. Yes, it develops. Okay, next we move on to the next question. Speaking about the next question, advantage of ET tube over LMA. So speaking of the advantage of ET tube over the LMA, less use of muscle is a false, prevents aspiration is the right answer. I'd rather go for the laryngeal mask airway and compare it with the ET tube. ET tube prevents the aspirations. Okay, because ET tube provides a definite airway protection. Okay, so we'll move on to the next one. The 21st question, what is used in case of contraindication of succinylcholine? So you cannot use the succinylcholine and you want to use the another anesthesia. We have a lot: rocuronium, vecuronium, atracurarium, cystacurarium. We have all of four. Among that, I feel rocuronium is the best alternative because it is a fastest acting, non-depolarizing agent, and intubation conditions for 60 seconds could be provided at 1.2 mg per kg. Okay, but if you're asking for the fastest acting, I prefer the rocuronium. If you are asking for the vecuronium, yeah, it's an intermediate acting agent, so you have to wait for 2 to 3 minutes. And other options like atracurarium and cystacurarium, it is useful in the case of renal or hepatic failure, but it is also intermediate. So you have to wait for 2 to 3 minutes. But in the rocuronium, it is very fast. Out of the options which I got from here, I prefer the rocuronium. Okay. So next, first sign of putrefaction. The first sign of putrefaction is bluish discoloration of lower abdomen. Bluish discoloration of lower abdomen is the first sign of putrefaction. Pretty straightforward question, people. Next, vitamin K dependent clotting factor. We have the mnemonic of company started in 1972. Company started in 1972. Was the mnemonic for vitamin K dependent clotting factor? Protein C, protein S, factor 1, 9, 7, and 2. Here the option 2, we have it, 9, we have it, 10, we have it, we don't have a factor 6. So factor 6 is an eliminated option here. So we have vitamin K dependent clotting factors are all except might be the option. So here the option should be the factor 6. Okay. So I always remember the parasympathetic innervation of cranial nerves with the vitamin K dependent clotting factor, because it is a 2, 7, 9, 10, and this one is 1, 7, 9, 10. Okay, sorry, 3, 7, 9, 10 and 2, 7, 9, 10. Sorry for that. It is a 2, 7, 9, 10 for the vitamin K dependent clotting factor, and it is a 3, 7, 9, 10 for the parasympathetic innervation. So I always combinedly remember that. If you want it, you can remember, or as you wish. You have a better mnemonic. Okay, so next we have a colon determined in X-ray by hostrations, because valvulae conniventis is basically for the small intestine, especially on the jejunum, is basically for the small intestine, especially for the jejunum, and a string of beards is a sign in the Crohn's disease. It's a sign in the Crohn's disease. Okay, here
Hello, Dr. Saktivel. I think your sound is not audible to us. Sorry for the inconvenience. I think there is some technical issues. Dr. Saktivel will be back soon. Please wait for some time.
Yes, can you hear my voice?
Yeah, I
Can
can
you
hear
hear my
you.
voice and see the screen?
Mm, no, I can't.
Okay, one second, let me put it up. Yeah. Can you able to
Yeah.
see the screen and hear my voice clearly?
Yes.
Okay, I hope it was. Sorry, we got a technical glitch. So the patient, we move on to the question number 32. So speaking about this, a patient who has a burn. Okay, so we are in the 24th question or we are in the 32nd now. We were in 24th question. Till what
No.
question I have to resume, I can move on to that question.
Please start from question number 25.
Question number 25.
Yeah.
Okay. So it was pretty straightforward questions, most of them. Okay. So the test used for medial meniscus injury. The test used for medial meniscus injury is McMurray's test, M for M. Okay, the other tests, Lachman, valgus varus, and anterior drawer are all go for the collateral, ACL injuries. Valgus and varus goes for the collateral ligaments. So the M for M, medial meniscus, it's a McMurray's test. Okay, so pretty straight question. Next, a child presents with the GTCS, the initial treatment of choice. The child presents with the GTCS, the initial treatment of choice. The first line of choice is always a BZD, people, benzodiazepine. So here you may argue with me, there is a midaz and the phenobarbital. Phenobarbital is outdated and the midazolam is used for the refractory status. So the ideal drug of choice here, we left out with this, is lorazepam 0.1 mg per kg. You can use a phenytoin, but as a second line, not as an initial treatment. Okay, so initial treatment of choices, lorazepam. Okay, now moving on to the next recommended WHO for CA cervix. We have left with the HPV DNA PCR, pap smear, acetic acid stain, and HPV RNA PCR. RNA is not used. Acetic acid stain, viral inspection with the acetic acid will provide you immediate results, but it is not suitable for screen and treat, not for the screening alone. Okay, so HPV DNA and pap smear we left out. HPV DNA is highly sensitive, but it requires a complex resource settings. So it is not used for the general public. It is used for only the development in a developed countries with the most suitable lab facilities. We use this HPV DNA PCR. So we go for the pap smear. So pap smear is a gold standard screening tool for the CA cervix. Okay. Next we go for RK39. pretty straight for the Kala Azar. RK39 is a diagnosis for Kala Azar. Kala Azar, the other name of the Kala Azar is a visceral leishmaniasis. Visceral leishmaniasis. Okay, next. A 50-year male with a positive family history presents for screening of CA prostate. What should be done? So I'd rather go for the PSA and DRE. And we can also use this acid phosphatase, but the acid phosphatase is an outdated marker which is not used in screening because it is elevated only in the advanced metastatic disease. And MRI is not a screening tool. It is whenever the patient is having a known cancer, we go for it. So here, by removing acid phosphatase and MRI, we left out with only one option, which is a DRE and PSA. So on a neglection basis or on the optimal basis, we can both go for the DRE plus PSA. Next, MOA for hormones in endocrine works mostly by negative feedback mechanism. Okay, next, which nerve injury in a Monteggia fracture dislocation? We are having two answers, but the most optimal answer or the most preferable answer always for the Monteggia fracture is posterior interosseous nerve. Okay, most preferable is posterior interosseous nerve. Okay, next we move on to the burn marks. So speaking about the burn marks, the patient has a burn over the full right upper limb and full anterior trunk and genital area. Total burn surface area. So speaking about the burn percentile calculation, head carries the 9%, upper limb carries a 9% with each. So both upper limb it is 18 plus 9, 27. And we have an anterior trunk as 18, posterior trunk is 18, which brought you with the 36, and each lower limb 18, so which brought you with the another 36. So 72 plus 27, 99, and genital area carries a 1%. This is a burn marking area. So speaking about the burn markers here, right upper limb, which means 9%. And then we have the full anterior trunk, which means 18%. And then you have a genital area, which is 1%. So 18 plus 9, 27, 28% is a option here, right answer here. So based on that, the burns more than 20% will require a formal fluid resuscitation. In this patient, 4 ml per kg per percentage of TBSA lactate, ringer lactate should be infused in 24 hours and half in the first 8 hours, remaining half for the next 16 hours. So Parkland formula, 4 ml per kg per percentage of TBSA, total burn surface area. You have to calculate that, and then you have to put a first half in the 8 hours and next half in the remaining 16 hours. Okay, in this patient, mostly he requires a ICU admission. Okay, that's what the discussion here. Okay, next we got the patient in ICU, intubated patient with the under sedation. What is the maximum GCS of this patient? What is the maximum GCS of this patient? So intubated patient with under sedation. Okay, intubated patient under sedation. So intubated patient cannot open his mouth. So vocals will be completely, or verbal part will be completely gone. So VT, they have mentioned it very clearly. The maximum, we go for the E4 and M6. These are the maximum scores. These are the maximum scores. M6 is obeys the command, but motor M1 to M6, M6 is obeys the command. M5 is localizes pain, M4 is withdraws pain, M3 is flexion, M2 is extension, M1 is none. Okay, and speaking about the E4 is spontaneous, E3 is to voice, and E2 is to pain, and E1 is none. So since the patient is intubated and he is on sedation, some may argue that E1, why not we go for the E1 and M3, sir? Yeah, but here the question is having a little trick that the maximum GCS that you can see on this patient, the maximum, okay, if forced, it numbers should be moved on to 10T. Okay, that's it. Next, we got this question. of Hari and Sita are brother and sister. Sita has a son who has been diagnosed with the Fragile X syndrome. So it's a straight Fragile X syndrome. Okay. What is the probability of Hari having a son with the Fragile X syndrome? So tell me, people, Fragile X syndrome. Fragile X syndrome is a X-linked dominant or X-linked recessive? Fragile
X-linked
X
dominant.
syndrome, X-linked dominant one. Since it is a X-linked dominant one, so it is a trinucleated repeat disorder due to the CGG expansion in the FMR1 gene, if I am right. Okay, so the inheritance pattern shows a very unique characteristics. Okay, so speaking about the Sita has an affected son, confirming she carries the Fragile X pre-mutation or maybe full mutation. Yes or no? So Sita's son is having a disease. That means Sita is carrying a Fragile X pre-mutation or full mutation. And her brother Hari is having a 50% chance of inheriting this FMR1 mutation from their mother. However, there is a problem here. It's an X-linked dominant. So males do not transmit the Fragile X syndrome to their sons because the son receives the Y chromosome from their father, not the X chromosome which carries the mutation. Yes or no? So what is the answer here? The answer here is 0 because they are asking for the Hari son with the Fragile X syndrome. Okay, the males carry from the father the Y chromosome. Here, the problem is with the X chromosome. Even though Hari had a 50% chances of carrying the mutation of this FMR1 gene, he did not pass to his son. Okay, so the answer here is 0%. So moving on to the next question. Female patient in gynae OPD with the recurrent history of abortion at first trimester. The recurrent first trimester loss, most common cause is always the chromosomal anomaly. Okay, most common cause of a recurrent pregnancy loss, recurrent abortion in the first trimester, it is always the chromosomal abnormality. Okay, apart from that, you have to rule out the antiphospholipid antibody as well as the thyroid and the pelvic ultrasound. Okay, these are all like a workup test, but mainly to rule out mainly the cause they have been asking. So chromosomal abnormality is the cause of the recurrent first trimester abortion. Some may argue it is an antiphospholipid syndrome, but the most common cause based on the rate, it is always the chromosomal abnormality. Okay, next, what is the step is not followed in rapid sequence intubation? Again, we got the emergency medicine question, people. Emergency airway management, you will initiate the RSI. Okay, RSI is a immediate securance of your airway while minimizing the aspiration risk. Okay, immediate securing of the securization of the airway while minimizing the aspiration risk. So speaking about that, the first step is preparation. You have to check for the equipment, monitoring, IV access, positioning, sniffing position, place the position, preparation, 2P. The second P goes for the pre-oxygenation. Second P goes for the pre-oxygenation, 100% O2 for 3 to 5 minutes to maintain the 8 VC breathe. And goal is to SP 100% on denitrogenation. Okay. The first P was preparation. Second P was pre-oxygenation. Third P was pre-treatment. Pre-treatment with the lidocaine or ICP or fentanyl or hemodynamic blunting. In children, we use as atropine. So pre-treatment, the third P. Paralysis with the induction. Paralysis with the induction is and positioning, protection and positioning. And the sixth P is placement with proof. Placement with proof. Okay, so these are the 6 P's of your RSI sequence: preparation, pre-oxygenation, pre-treatment, paralysis, protection, and placement. So here, manual ventilation is not performed. So option B is except. The exception option here is the manual ventilation. Okay, that is a key feature which is distinguishing from the RSI to the standard intubation. Because after administering the medications, we directly go for the intubation without a BMV. Okay, in RSI, we directly after after administering the medication, we directly go for the intubation without the BMV. Okay, so that minimizes the gastric insufflation and aspiration risk, because it is mainly the RSI is performed for the like a minimization of aspiration risk. Okay, so this is what it is. So the option here is a manual ventilation. Okay, next, a febrile patient with a history of mass in the right iliac fossa with the blood-stained mucoid cells. Okay, blood-stained mucoid cells. Okay, next, what is the cause? So amoeba, amoebic colitis with the entamoeba histolytica will form the inflammatory granulomas with the mass. Okay, it pretends like a colon cancer. It pretends like a cecum, which is affected, but there is a ulcers in the colonoscopy, and that follows the blood-stained mucoid stool. Okay, amoeboma will be the option because the patient is febrile. Okay, in colon cancer, it is possible, but the patient is afebrile. In intussusception, we have that stool. What is that common stool we get in that intussusception? Currant jelly stool. Okay, we get that currant jelly stool in the intussusception. Okay, and we also get a currant jelly sputum. Where you get a current jelly sputum? Klebsiella pneumonia, where you
Absolutely.
see Friedlander pneumonia, because Klebsiella is often called as Friedlander bacillus. Okay, next we have a diverticulitis. Diverticulitis, you may see the left side, left-sided pain, especially with the sigmoid colon. Fever is present, but not the characteristic bloody mucoid cell. The bloody mucoid cell and febrile and pain in the right iliac fossa is the three clues which directs you to the amoeboma. Okay, next, moving on to the next. The young patient got injury over abdomen 1 week back, now presents with a pulsation like feel over the abdomen. Pulsatile abdomen, it is directly abdominal aortic aneurysm. So that's a clue here, pulsation on the abdomen. So physical examination, you will see the pulsatile expansible mass. Location varies by the injury site. So you have the history of injury, you have a pulsation, definitely it is passing it through the abdominal aortic aneurysm. Imaging, CT angio is a gold standard. Ultrasound is a bedside assessment. Okay, check for the NPO status, arrange emergency surgery. Okay, arrange for the coil and repairing. Okay, next, a pregnant woman with a history of hypertension at 20 weeks of gestation has an increased uterine pulsation in the USG. Okay, very good. So 20 weeks of gestation, what are the possible things we can see in this patient is all the options we can see. Yes or no? We see the gestational diabetes, we see the chronic hypertension, and we see the preeclampsia. All three things you can see in the 20 week of gestation patient. But here comes the clue, uterine pulsation in the USG. That is the abnormal uterine artery Doppler, high pulsatility index, persistent notching in the uterine artery Doppler, you will expect to see in the preeclampsia patient. So all the three can be expected, but the clues narrows down as to the preeclampsia. Okay. Chronic hypertension, why not? It could be the chronic hypertension, sir. Yes, it is a pre-existing condition. Okay, not the gestational hypertension condition. Okay, so if it is already diagnosed, not predicted by the Doppler. Okay, so gestational diabetes, not predicted by the urinary artery Doppler, as I said. The gestational diabetes mellitus, the optimal test for the GDM is OGTT. 75 mg of OGTT is the optimal test which we run. Okay, so here the option narrows down us to preeclampsia. Okay, next we move on to the next question, question number 40, which is a GCS calculation again. RTA presents with a full consciousness. After an hour, he opened the eyes with a painful stimuli. Eyes open to the painful stimulus, goes for E2. Speaks inappropriate words. He is not oriented. Remember, he's not oriented. He is speaking an inappropriate word. Word goes for V3. Okay, and flexor withdrawal to pain. Flexor withdrawal to pain, clearly it was going for M4. M4, V3, E2. By combining it, we get it up. 9. Okay, and GCS of less than 13 indicates brain injury, and GCS of less than 8 demands intubation. Okay, management in this patient suspecting the brain injury, we have to order urgent HCT with the neurosurgical consultation and wait for the intubation, arrange the intubation thing because the GCS can fall on any time because it's a borderline. Manage his ICP, identify the lesion and remove it. Epidural hematoma would be the most common thing, secondary to the RTA. Okay, we move on to the next one. What is found in the case of rabies? Negri bodies. Clear-cut questions. Okay, negri bodies are the eosinophilic cytoplasmic inclusions. Okay, inclusions. You will see it. Where you will see? In the pyramidal neurons of your hippocampus. Pyramidal neurons of your hippocampus. What is that pyramidal neurons of your hippocampus? We used to call it Ammon's horn. And also you will see in the Purkinje cells of your cerebellum. Okay. So negri bodies is a common eosinophilic cytoplasmic inclusion bodies which is found in the rabies. Maybe the other options might have been given to you. Since I can't find the other options, negri bodies, since it is the right answer, I'd rather go. Immediately you have to DFA. We have to do the other ones. Okay. Next. Next, we have question number 42. A patient with a dry cough after adding antihypertensive. What is that medicine? Typical one. What is that? Enalapril. ACEIs cause cough, severe cough. So what is the management of this patient? Shift the drug from what to what? ACEs to ARBs. So the ideal choice of a change of new drug is a losartan in this case. Okay, ACEs produces a cough. Okay, next. A patient with a history of RTA, so RTA, with the initial loss of consciousness, lucid interval, okay, gradually decreasing loss of consciousness. So loss of consciousness, lucid interval, further deterioration. Typical epidural hematoma. Typical epidural hematoma, lucid interval with the initial loss and followed by the further deterioration. Okay. So here we have this. Epidural hemorrhage is the right answer. Okay. Subdural hemorrhage will not proceed with the lucid interval. Subarachnoid hemorrhage often causes a thunderclap headache. So here you will see the thunderclap headache. And the subdural hemorrhage, no lucid interval. I hope my handwriting is okay for you guys. Okay, next. Intraparenchyma hemorrhage, we see the focal deficits on the brain, not just like a lucid interval and things. Okay. And next, you will see here the patient with the epidural hemorrhage having a radiological feature. What is the radiological feature? Biconvex with the hyperdense lesion. Biconvex with the hypertense lesion, especially near the temporoparietal area, because that is where you will see the middle meningeal artery. Middle meningeal artery is the most common artery gets affected during the epidural hematoma. Okay, especially the fracture onto the brain, the weakest point of the skull, derion, below where you see the middle meningeal artery passing. Rupture of that middle meningeal artery could result in epidural hematoma. Okay, so you will see the biconvex with the hyperdense lesion on the epidural hematoma. So most common intervention for this patient is surgical evacuation if symptomatic. Okay, surgery, you have to call the neurosurgeon. Okay, next, going on, baby of 9 months got a vaccination for measles. Why? So here, maternal antibody helps to prevent the measles up to 9th month is the right answer. Okay. Child hasn't developed immunity till 9th month is not. Infant immune system is functional from birth. So this is wrong. Passive adaptivity comes only after 9th month. This is also wrong. Passive immunity means antibodies which is transferred from mother. So which is present right from the birth, not acquired in 9th month. Okay. So next, management protocol for the stag-on calculi. For stag-on calculi, we always do the PCNL. Why we are doing a PCNL for the stag-on calculi? Because we have the ESWL and the PCNL. So the indications for the PCNLs where the calculus should be more than 2 centimeter. Okay, if the calculus is more than 2 centimeter, we do the PCNL instead of ESWL. And the second thing, the calculus should be the stag-on calculi. Then we put a PCNL. Okay. Number 3, if the calculus stuck in the diverticula, we go for the PCNL rather than the ESWL. Okay. Why? Because the stag-on calculi, the burden is too large and it have a pointy end. If you are passing it through the ESWL, the points may rupture the ureter while passing down. So PCNL is a optimal one. Either you through the thoracic approach or abdominal approach, however you want to do. Okay. And success rate is 90% if you ask me. Okay. Next, Warthin tumor. Warthin tumor is mostly associated with the parotid gland. Warthin tumor is mostly associated with the parotid gland, which is pretty straight question. Next, which of the following is not a typical first generation antipsychotic? Okay, so risperidone is the second generation. Okay, chlorpromazine and haloperidol both are first generation. Among that, haloperidol have a high potency, okay, with a strong D2 antagonism. So you will see the first generation with the more amount of EPS, with the tardive dyskinesia, acute agitations, you will see more in the first generation rather than the second generation. And second generation will have a multiple mechanism of action. So see here, risperidone will have a D2 and 5-HT2A activity also. 5-HT2A antagonism also. What are the common side effects of risperidone? We see the patients with the weight gain, hyperprolactinemia, because it acts on the D2 receptor. And you will also see the metabolic syndrome. Okay, 5-HT2A. Okay, these are the notes. So typical straight question, risperidone. It requires your mugging up skills. I hope your mug up skills are good. So next, a patient with a pancreatitis presents with a Cullen's and Gray Turner sign. Okay, Cullen sign is a bluish discoloration around the umbilicus. Gray Turner sign is a bluish discoloration around the flanks. Okay, what is the cause of this sign? Intraperitoneal hemorrhage, extravasation of blood through the rectal sheath. Okay, subcutaneous fat necrosis, intra-abdominal infection. We rule out the intra-abdominal infection because it's not coming up with it. So we have this 3: intraperitoneal hemorrhage, subcutaneous fat necrosis, and extravasation. Speaking about the fat necrosis, it indicates the blood tracking, okay, not the fat necrosis. So because bluish discoloration goes for the blood, not the fat. Bluish discoloration goes for the blood, not the fat. So we rule out the fat necrosis. So we have only 2: intraperitoneal hemorrhage, or maybe the extravasation of the blood through the sheath. So Cullen sign is bluish discoloration around the umbilicus. Okay, and gray tunnel sign is a bluish discoloration around the flanks. So both of them are in the track of the rectus sheath, and we have it in the retroperitoneum, not in the intraperitoneal cavity. So we rule out this intraperitoneal hemorrhage also. So at the further end, we left out with extravasation of blood through the rectal sheath. So the optimal answer here is extravasation of the blood through the rectal sheath. Okay. So these are the one. Okay, next. Res ipsa liquidator, thing speaks for itself is the one. Okay, things speaks for itself is a term for res ipsa loquitur. Okay, next. Which of the following ethical role is vital in research involving the human participants? Which of the following ethical role is involving the vital human participants? Okay, the first thing is informed consent, justice, confidentiality, and beneficence. So the most of ethical role is vital in research informing is informed consent. Absolute requirement. The patient must know the risk, procedure, alternative, voluntary participation. Okay. The patient must know the risk, benefit, procedure, alternatives, and voluntary participation. All of them. Okay. And next, which of the following features of the colonic adenoma suggest increased risk of malignant transformation? Okay, colonic adenoma risk factors. Speaking about the risk factors, tuberculous variety having a tuberculous adenoma, which has a 5, and villus adenoma, which has a 40%. So tuberous villus, which has a 22%, sorry. Tubular, which have a 5%, and villus, which have 40% risk. Adenoma of more than 1%. Okay. More than 1% significantly increases, maybe more than 1%. Okay, so out of the options which has been given here, villus will have the increased risk. Okay, villus have the highest risk of malignant transformation. Okay, speaking about the percentile calculation. Next, patient with the honeycrustal lesions. What is a causative organism? Honeycrustal lesions, which is a non-bullous, is the most common one. So the option here are Staphylococcus aureus we have and Streptococcus pyogenes we have. Okay, most commonly we see on this both. I got a both options. So maybe if the options is right or wrong, maybe you may correct me in the future. Both will have the honeycrustal lesion, but if you ask me the frequent and the most common one, I will go for the Staph aureus rather than the Streptococcus pyogene. Okay, so but if you see the honeycrustal lesions, both are possible. So maybe if the answers GAS or GBS, correct me if there is a optional mistakes. So these are the one. Next, for ovulation induction of the patient, for the ovulation induction of the patient, we uses mainly or most commonly used one. Okay, speaking about that ovulation induction, the most common one was letrozole, emerging standard, but the traditional standard was clomiphene citrate. So both A and B are used, but nowadays the recent guidelines favors for the letrozole over the clomiphene. But in the most commonly used one, if you are asking, I rather prefer in the books it is a clomiphene citrate. So if you are booking clomiphene citrate, it could be the right answer. Okay. So
So there
next,
was a scenario, means ovulation
yes.
in case of regularly menstruating woman.
Okay. So see here, we got two options, letrozole and clomiphene citrate. Okay. Letrozole is an aromatase inhibitor, okay, which decreases the estrogen and increases the FSH through the feedback mechanism. Yes or no? So while the clomiphene citrate is a SERM, selective estrogen receptor modulator. So speaking of that, it blocks the estrogen and increases the FSH. Both are effective. Okay, but for the regular 3 to 7 or 5 to 9 days of cycle, I rather go for the clomiphene citrate. Okay, I rather go for the clomiphene citrate. If you're asking me with this option, I go for the clomiphene citrate. Hopefully. Next, hemophilia. So hemophilia iatrogenic is the most common cause. Okay, especially secondary due to the liver biopsy.
Sir, in the
Okay,
question
next.
number, sir, in question number 53, the Vignette mentioned coca in the chain also.
They mention
Coca in chain.
cocci.
In chain, sir, chain.
Okay, cocci in clusters or in chains. Then I go for this pyogens. Okay, next. Painless palpable gallbladder. I'd rather go, we will discuss that at the end of the session because we have 20 more questions to go. We will finish up the review and then we will clear all the doubts one by one. Hopefully it gets pile up with the points. So painless palpable gallbladder. So it is a Courvoisier sign. Painless palpable gallbladder is especially in a jaundice patient is your Courvoisier sign. Courvoisier sign is seen in. It is a typical straight question, pancreatic carcinoma. Okay, classic Courvoisier sign is seen in pancreatic CA. Okay, next. A patient under ATT presents with the jaundice. Okay, what should be done next? So AATT, most of the drugs are hepatotoxic. So you will have a jaundice, patient develops a jaundice, indicating the potential drug-induced hepatotoxicity. Okay, so drugs like isoniazid, rifampicin, pyrazinamide, everything is there. So first thing is assess the severity. So while assessing the severity, you have to you have to monitor the LFT and the assessment of the status. So second thing is stop the hepatotoxic drug, and third is substitute the drug, and fourth is sequential reintroduction. So first thing, assess the severity. Second thing, stop the hepatotoxic drug till the LFTs improve, and then use the substitute regimen, which is like a streptomycin, ethambutol, fluoroquinolone, and then once the LFTs has been normalized, reintroduce the drug. So in this situation, maybe the options may be which is not on the right way. So we have the stop ATT, we have replaced 3-week ATT regimen, continue ATT and monitor LFT. So first thing is assessment of the severity by monitoring the LFT, then the stop ATT, then replace it with the substitute regimen, then sequential reintroduction. So based on the option which has on the table with me, I rather go for the stop ATT. Okay, because you have to assess the LFT first. Based on the LFT, you have to stop it and you have to do the alternate non-hepatotoxic. Then you have to, once the LFTs are normalized, then you have to initiate the other ones. You have to reintroduce the therapy. Okay, clear? Next. A pregnant lady with a history of twin pregnancy, 1 abortion, and 1 live birth. The pregnant lady with a history of 1 twin pregnancy with a 1 abortion and 1 live birth. What is the obstetric formula? Answer here is G4P2 or G4P3, G3P2, and G3P3. So patient is having a 1 twin pregnancy and 1 abortion and 1 live birth. Okay, patient is having a 1 twin pregnancy and 1 abortion and 1 live birth, and now currently she is pregnant. So G4. The gestation is G4. Now going for the P. Okay, number of deliveries, which is after 20 weeks, not the number of babies. So here we have 1 twin delivery and 1 live birth. So G4P2, I go for it. Okay, in the GTPL, G goes for gestation, which is the total number of pregnancies. So here she has a 1 pregnant. Twin pregnancy should be considered as 1. So 1, 1, and 1 abortion and 1 live birth. So we have a G4. Here we have the G4. And speaking about the P, we have the preterm babies. Okay, sorry, completely term babies. So deliveries within after the 20 weeks. Okay, delivery is after 20 weeks. She has a one live birth and one twin pregnancy. So we consider it as two because one abortion which was happening before the 20 weeks. So we don't take it up now. And since we are having a one current term, one pregnant lady with the pregnancy term has not been mentioned, so we cannot able to do it. So G4P2 is the ideal option here. Okay, next. Next we have the question number of 59. A diabetic patient with a history of right lower zone consolidation. What is the treatment of choice? So right lower diabetes consolidation, mainly it is a community acquired pneumonia. Okay, community acquired pneumonia and the diabetic patient is a topic of interest here. So especially the options here, we are having a clindamycin, amoxicillin, ceftriaxone, and levofloxacin. I rather go for the levofloxacin. Okay, so many people ask me, yes, why don't you go for amoxicillin, which is good for strep pneumoniae, and or maybe the clindamycin for the typical community acquired pneumonia. Why you are not going it, and why you are going it for the levofloxacin rather than? Because they didn't give the organism of choice, and they are giving it as a diabetic patient on the treatment of choice. So speaking about the diabetes and the community acquired pneumonia, respiratory fluoroquinolone like levofloxacin will have the excellent activity with the both typical organism and atypical organisms like mycoplasma, legionella, chlamydia, H. influenza, strep pneumoniae. Both atypical and typical levofloxacin will be the single agent coverage. Okay, so I rather go for the levofloxacin over the amoxicillin or clindamycin because amoxicillin will cover strep pneumo very good. Okay, reasonable OPD choice of antibiotics is amoxicillin, but it lacks the atypical organism coverage. Okay, and speaking about the diabetic, if you give the amoxicillin with the more severe disease, diabetes is a complication with the poor wound healing, so it takes a larger time, so we have to finish the infection in a very shorter period. Okay, and clindamycin, it covers the anaerobe with some gram positive, but CAP, I don't think so. It's empirically we can use it. Cultural positive, sensitive, yeah, we can use it. But as a broad spectrum, we have the ceftriaxone and levofloxacin, but ceftriaxone, it will cover only the gram positive, gram negative coverage. But IV route, it should be combined with azithromycin, but at the acceptable choice. By considering all the factor, I will go for the levofloxacin. Okay, next, a patient with a history of chronic cough, a patient with a history of chronic cough since 4 months, presents with a bilateral hilar lymphadenopathy. Okay, here comes the chronic cough with the bilateral hilar lymphadenopathy. So we have the here answer of multiple myeloma, and we have here sarcoidosis. So patient, chronic cough, bilateral lymphadenopathy. The options I rather go for is the sarcoidosis. Okay, is a chronic. It's a classical presentation of your pulmonary sarcoidosis. Okay. While go for the multiple myeloma, BJP should be there, bone pain should be there, hypercalcemia should be there, renal dysfunction should be mentioned, rather than this only one particular lung area. When you are focusing on the lung area, I rather go for young and middle-aged adults. I rather go for the BHL and the chronic cough. I go for sarcoidosis. Okay. As there is no other mentioning values like BJPs or maybe like a renal dysfunction markers or nothing else has been given. Okay, next, drugs that affects on hearing. Drugs that affects on hearing. That is an ototoxic drug. Ototoxic anti-tuberculosis drug, it's straight to streptomycin. Straight answer, because ethambutol affect your optic neuritis, pyrazinamide and isoniazid affects your liver, and the ototoxic one is your streptomycin. Okay, vestibular toxicity is associated with streptomycin. Pretty straight question, people. Next, a 62-year-old female with a P2L2A1 with the amenorrhea since 6 weeks. She has a history of dilatation and curettage. Okay, 6 months back. Okay, what is the diagnosis? So 6 weeks of amenorrhea following a DNC, okay, mostly associated with the Asherman. We don't see the options, other options here. If you see the other options, it will be good. Okay, but basically, as Asherman syndrome develops following endometrial trauma. So this patient have underwent a DNC 6 months back. That means the endometrial trauma, which is secondary to this DNC. The adhesions obviously obliterate the uterine cavity. So that in turn, prevents the normal proliferation and the menstruation. That's why she is developing a amenorrhea after this 6 weeks after this DNC. Okay, so typically it goes for the Asherman syndrome. If you have other options, we can rule out the amenorrhea differential diagnosis. Okay, more hopefully, eventually we get that later. Okay, how will you differentiate iron deficiency anemia versus anemia of chronic disease? Okay, pretty straight question. Serum ferritin. Low serum ferritin is seen in iron deficiency anemia. In a iron deficiency anemia and anemia of chronic disease is a problem with the hemoglobin. And in the heme especially, in the heme, we are having two things, iron and other proteins. So here, serum ferritin is the option. Serum ferritin is a single test to differentiate iron deficiency anemia from the anemia of chronic disease, because ferritin will be low in the iron deficiency, while normal or high ferritin will be in the anemia of chronic disease. So speaking about that parameters, in iron deficiency anemia, you will have a low ferritin, high TIBC, and low transfer in saturation, and microscopic or microcytic hypochromic anemia, RBCs. Okay, so you will have the same microcytic hypochromic RBCs when the anemia of chronic disease also, but you will see the low or normal TIBC, and you will see the low transfer in saturation, and you will see normal to high ferritin. Okay, so here comparing with the TIBC and transfer in saturation as an option, while kind of contrasting both, I rather go for serum ferritin. Okay, it's pretty straight question. Next, a patient experienced worst headache of the life, that is a thunderclap headache. Patient experienced worst headache of life, that is a thunderclap headache. Thunderclap headache is seen in, pretty straight question. Thunderclap headache is seen in SAH. For SAH, do CT head. Some people argue, why not the MRI? Okay, MRI is the most sensitive for subacute hemorrhage, but it takes longer to perform and most of the centers will not immediately available and is more expensive. So when the patient is in the acute setting, CT provides the rapid and accurate diagnosis when SAH is readily detectable. Okay, and speaking about the thunderclap headache, approximately 85% of the subarachnoid hemorrhage are the ruptured cerebral aneurysm. We got this patient who has been presenting to us with the uncontrolled hypertension, and he failed to say us the history while examining, got a history from the other hospital around 6 months ago. So he got a abdominal, he got a SAH earlier with the aneurysmal rupture, where the coiling was done in Ireland around 12 years ago. So in this patient, the optimal treatment managed was to keep the BP on the lower side. But the patient got approximately, the BP of 170 over 100 all the time. So he have a risk of re-rupturing of aneurysm. So we had started antihypertensive. Hopefully, within 2.5 weeks, we are seeing his BP level on 100 over 90. So hopefully he gets recovered and he don't have another rupture of perianeurysm. Hopefully. Okay, let's go for the next question. A pregnant woman on 28 week of gestation presents with the painful bleeding. Okay. Pregnant women with the painful bleeding on the things. Okay. So what is the most common answer here? What is the cause? We have the abruptio placenta, we have a placenta pravia, and we have the vasa previa. Okay. 28 week of pregnant women which is presenting with the painful bleeding. So speaking about the third trimester bleeding, people, speaking about the third trimester bleeding, we are having a painless bleeding, we are having a painful bleeding, and we are having a painful bleeding with the, we are having the painful bleeding with the ruptured or the organ dysfunction. Okay, out of that, the painful bleeding on the third trimester, what kind of things we can expect as a differential diagnosis, people? Shoot me up the diagnosis, the painful bleeding at the third trimester.
Abruptio placenta, uterine rupture, or
Okay,
labor
very good.
pain.
Okay. So the painful things is three things: abruptio placentae and preterm labor, because the bleeding with the regular contractions or back pain could happen. And third, you said, as you said, it's a uterine rupture. It is very rare, but a very serious things. And apart from that, any dilatation or cervical infections could cause.
So,
Yes.
I think in this question, there was a mention of not of a 28 week of gestation. It was at 38 or 39 weeks of gestation.
Okay, 38 or 39 week of gestation.
Oh,
38 or
and
39.
there was and in history there was painful bleeding with a tender uterus.
Mm-hmm.
Yes.
Anyway, abruptio placenta is the answer because it's emergency here.
Yes,
Maybe the
and the D option was uterus rupture.
okay. So mainly these things. So maybe we will have a discussion later with these things, the added options and the differential diagnosis. Maybe we will discuss that at the end of the session. What are the differential things that you may get? Okay. So next, source of production of estrogen in male, pretty straight question. Next, we got the source of production of estrogen in male. It's a testis, pretty straight question. Next, the child with a history of diarrhea present with a sunken eye, skin pinch, goes back slowly within 2 seconds. Child readily drinks the water. What is the management? Okay, the patient is having this dehydration. Patient is having a dehydration, severe dehydration. So the management protocol is ORS 75 ml per kg for over 3 hours. Okay. And apart from that, zinc supplementations we can give and reassess every 1 to 2 hours for the rehydration. Okay. And what are the things you may see as a danger sign that you have to say that to the patient's caretakers? When the patient is unable to drink or breastfeed, it is a danger sign. Vomiting everything, it's a danger sign. Convulsions, it's a danger sign. Blood in stool, it's a dangerous sign. Lethargy or unconsciousness, it is a danger sign. So in this patient, we are having the pediatric dehydration. Speaking about the pediatric dehydration, we classify them as a moderate to severe. Okay, restless, irritable, sunken eyes, low skin pitch. It is a moderate dehydration. Lethargic, unconscious, very sunken eyes with a poor perfusion. You may have the severe dehydration. In this case, patient is having a moderate dehydration, so we go for the ORS plus zinc with the danger sign explanation. Okay. Since it is a danger sign explanation, I have told what are the danger signs. Okay, next, case-based question. A patient with a hemorrhagic shock. What is the initial physiological response? Class 1, minimal symptoms, vitals will be normal, compensatory mechanisms will be activated. If it is a second class with the 15 to 20%, 30% of the loss, tachycardia, narrowed pulse pressure, decreased urine output, and class 3 will develop hypotension, altered mental status, and oliguria. While class 4, which is more than 40% loss, patient will have a profound hypotension, altered consciousness, severe organ hypoperfusion. So in this case, hypotension, widened pulse pressure, bradycardia, decreased urine output. So patient with a hemorrhagic shock features, the initial change they have asked. So initially patient's vitals will be normal, and then it progresses into tachycardia, which here is not there. Bradycardia was mentioned. Narrowed pulse pressure, here it was mentioned as widened pulse pressure. Patient will have a decreased output. That is the earliest change. Hypotension will not appear, sir. Yes, it appears at the later. When it follows the altered mental status, oliguria with the hypotension, yeah, it appears later. But at present, the initial change was the question here. So we have a decreased urine output. Next, error. They asked about the medication error. Decimal point error. Decimal point error is a prescription error. Decimal point error is a prescription error. So I tell you one interesting story. Okay, when I was in a country around like 3 years ago, I was prescribing the patient with the 2,500 units of heparin. Okay, I was prescribing 2,500 units of the heparin, and then 2 days later, the patient has been presenting to me that the patient's attender has been presenting to me that they were been saying, doctor, we are not afford to buy that because a lot of uh, the money is going for the buying that injection that you have prescribed. Can you prescribe something which is cheaper? I said, like, I prescribe only 2,500 units of heparin. That is cheaper. So then I went in and I cross-checked. They told me like we have to do around like 10 vials a day. I said, like, why? Then I went back and I checked on my notes. I wrote only 2,500 and patient was buying 25,000, 25,000. Why it was the drug chart, the nurses used to write the drug chart in the IPD. They have written it as 25,000 instead of 2,500. So the decimal point comes as a prescription error. Okay, thank God that patient did not got any bleed, so I escaped from the suing. Okay, anyway, what I written in my notes, it was only 2,500. But what was written in the chart? 25,000. So when at 25,000, they are buying a 10 vial of a 2,500 units. Okay. Next, salivary gland is lined by what epithelium? Salivary gland is lined by what epithelium? Pretty straight question. Pretty straight question. Columnar epithelium. Okay. First pass metabolism is avoided by which of the following routes? IV. Which of the following routes? IV. Some will say, sir, why not the sublingual? Why not the topical or transdermal? Sublingual is also right. Okay, but the basic one is buccal, rectal, IM, IV, inhalation, except oral, because the oral one goes into the liver and then goes into the systemic circulation. First pass metabolism means the amount of drug or the part of drug which is metabolized in the liver, first pass metabolism, which means the part of drug which is metabolized in liver, prior entering into the systemic circulation.
Excuse me, sir.
Prior entering into systemic circulation. Yes.
So in this question, there was no mention of IV option. There was in place of IV, there was intramuscular route.
Okay, IM will also
Yes,
go
sir.
there. Okay, IM or subcutaneous will also go. So the routes which avoids the first pass metabolism was buccal, rectal, inhalation, IM, subcutaneous, sublingual. Okay. So we got about like a 70 questions. So we have done the discussion, most of the things based on the options which has been given to me through the recall. I have made this session. I hope the session might be helpful to you. So I'll be available for the discussion for the next another 5 minutes. I hope you guys have enjoyed the session. Hope it will be helpful. No, IM was the option. Yes, IM was the option. Anyway, IM will also avoid the first pass metabolism. Okay, IM, sublingual, rectal, and buccal, inhalational, all the things, because oral route will goes into the liver. First pass metabolism is the metabolism which occurs in the liver, where the part of drug is getting metabolized in that liver before entering into the systemic circulation. Okay, so I hope the session might be helpful to you. I hope the session might be helpful to you. And we have discussed the various topics. So I hope it all goes good. There are further recall questions will be discussed in further. Okay, I don't want to waste much of your time because it's been already a very long session, about 2 hours, right? So I hope it was helpful to you guys. So if you have feedback or if you want to say anything, you can say it in the chat. If you have nothing, then we will wrap up the session. Post more question on the Telegram so that I get that, and you may get it in the further discussions.
Hello.
Yes, I think it was done.
Yeah. Thank you so much, Dr. Saktivel sir, for the excellent and very clear discussion.
Okay, I hope I helped everybody. So thank you. Hopefully it, everybody helped. Okay, sure. Thank you.
Leave.